Good evening, everyone. Welcome to the Lead Extraction Workshop webinar. I'm Yumei Chan, an electrophysiologist at the Mayo Clinic and the director of Device Lab. My colleague, Dr. Siva Mupuro, is the co-director of Device Lab. We will be together chairing this program. This webinar will be held quarterly in a case presentation and discussion format. So this is our first session. Thank you for joining us. In each session, we plan to present a couple of interesting and challenging extraction cases from a Mayo enterprise and from you if you are willing to participate. Through this educational platform, we will learn from each other about the lead extraction indications, different approaches and techniques. We will be together and advancing our knowledge and the skills for safe lead extraction. I want to thank CV department leadership and the CV education support to organize this webinar. Before we get started, I would like to invite our department chair, Dr. Paul Friedman, and to give us opening remarks. Dr. Friedman is not only a well-known device implanter, and is also excellent lead extractor. As you know, he is the mentor of many of us and taught me how to do the lead extraction when I was in the fellowship and then later on as a faculty. So Paul, please.
Dr. Cha, Dr. Mopuru, thank you guys. And you know, when you think about it, of all the procedures that we do, and there are many, lead extraction in some people engenders an enthusiasm and in some a dread or terror, because it is potentially a very high-risk intervention that can be life-saving for a patient. And you know, really through the leadership of the two of you and others in our group, we've put together approaches and strategies to address many of the common questions you have if you need to remove a lead. Should it be done in the operating room? What's the role of a surgeon? Can we safely do it in the EP lab, where imaging and logistics might be simpler, but surgical support more complex? And it's striking when you think about it that roughly 85% of leads that might be removed are capped. And that may or may not be the right thing for a given individual, but we do know that capped leads have a small risk of infection, of vascular congestion. MRI becomes more difficult. And I'm not saying these comments to say we should extract more leads, but rather we should be thoughtful about every time a lead is no longer in use or poses a potential problem, that we have the confidence to take the right strategy. And I think through these types of case discussions, we do learn from each other what works, what doesn't work, and grow. So I'm delighted that you selected this webinar on lead extraction and look forward to seeing the cases.
Thank you, Paul. So we're going to start this first session. So Dr. Mopuro and I prepared two cases. So I'm going to start with the first case. Depending upon the time, if possible, we'll present the two cases. Our faculty and the cardiovascular surgeon, Dr. Agami, will be joining us later in the session because he's currently having another commitment.
Dr. Chow, maybe we should make it clear to the audience if they have comments, either give us, send us a message on the chat box. We could upgrade you to a panelist. If you're willing, we could let you speak up on the panel, or just put up your questions. If you have a different suggestion, if you have done it differently, we are all here to learn today.
So let's start with the presentation. And then Dr. Mopuro will be moderating this session. We have no disclosure, and these the learning objectives. So the case is a 48-year-old female. In year 2000, when she was 27-year-old, had an episode of syncope while sitting in the passenger seat. By the report, she was out for about 20 minutes. She was brought to the local hospital, and the subsequent evaluation confirmed a congenital lung QT1 diagnosis. Echocardiogram was normal, and she was treated with beta blocker. Initially, it was metoprolol, and later on changed to Nadolol at 60 milligram once a day. In 2021, last year, she was referred to our genetic clinic for consultation. So this was presenting ECG. As you can see, the T wave has a wide base with a QTC interval 480 milliseconds. So there was some features of lung QT1 syndrome. In year 2000, a patient received a single chamber ICD in the local hospital. The generator was changed in 2010, and that is Boston Scientific Telegene. The lead is Guidant Endotech Endurance, and then it's a time lead. And then since the device implant, patient has never required RV pacing. And when she was here, the device interrogation showed elevated RV pacing threshold at 5.5 volt at the pulse width 1 millisecond. Patient received one episode of an inappropriate ICD shock for sinus tachycardia in the early year, but never received appropriate ICD therapies in 21 years. So last year, when patient was here for the consultation, that was extensive discussion between the consultation providers and the patient. So the final shared decision making was to remove the ICD along with the lead. So this is not the case of lead infection or generator infection. So does patient meet the criteria for ICD lead extraction? So if we look at the 2017 HRS expert consensus statement on CIED lead management and extraction, that's actually a 2B indication for lead extraction. So the lead removal may be considered in the setting of a normally functioning non-recalled pacing or ICD lead for selected patient after a shared decision-making process. So
now, Young Mei,
yes.
For the lead, that we noticed that the thresholds are high in this particular patient, and should we consider that as a normally functioning or something, at least the characteristics of stimulation or abnormal in this patient?
Yeah, it's a good question. The pacing threshold was elevated, but having said that, you could say yes or no, because the patient never required pacing. So if patient required pacing with such elevated pacing threshold, of course, patient would need a new lead. But in the setting of without needing the RV pacing, I think that will be very soft, talk. This is the patient need the lead revision at this point.
So I think even if and I know we're going to go into the details of the case. So before going into lead characteristics that kind of weigh into this, one of the questions that I think would be useful to hear some comments on is, what would you quote? And some people just say, I don't want a foreign body inside of me, but what would you quote her as the risk of, for example, removing the device and leaving the lead, or just abandoning the system versus removing it? Because we know there'll be an extraction risk. In someone who's relatively young, one lead, leaving it alone, what's the risk? What do you tell people?
Yes. So overall, we have really balanced the risk and the benefit. As Paul, you alluded, is we could remove, if the decision is made, we don't need the ICD. So we can easily remove the generator. We could abandon this lead, and or versus to remove the lead. So the risk for massive bleeding with SVCT or RV rupture or death is roughly about 0.5% in the tertiary care center. So in that case, that's the risk. But for this patient, age 48, so if we want to keep this lead for another 40 years, that is a quite bit downside. So that's why that was extensive discussion, and the long-term ICD benefit from a physician standpoint appear to be low or small. And the patient has a desire to remove the defibrillator along with the lead. So that's why after balance everything, we brought patient to the lead extraction lab. It's a great question.
Yeah, I mean, it's one that is a real struggle, I think. And
Yes.
I think you'll get into more detail here. And the kinds of questions that also come into play when you're thinking about that case is dual coil or single coil. Is it a Gore-Tex covered coil or not because of the potential for ingrowth? And maybe those factors will come out as the case unfolds.
Yes. And also the decision was made based on the Mayo Clinic experience. So this is Dr. Ackerman and his colleagues published the article at the Heart Rhythm Journal in 2016. So this is the ICD explantation for overdiagnosed or overtreated congenital lung QT syndrome. So the study included over 1,200 consecutive patients, and these patients had been referred to the Mayo Clinic for evaluation of possible lung QTs, and subsequently were either diagnosed with lung QTs or dismissed as normal. And of these patients, 170 patients had ICD, and most of them, 157 patients, was confirmed with lung QT. And of these 1,200 plus patients, 1% or 12 patients had ICD removed. Before the ICD explant, 5 of the 12 patients experienced inappropriate shocks, up to 54 shocks in one patient. In addition, 4 had device-related infections, 9 had device or lead malfunction. And this study followed the patient for more than 5 years. So none of these patients had a breakthrough cardiac rhythmic event. So the study concluded that unnecessary ICD placement in lung QT syndrome can be associated with potential complications and subsequent anxiety. I think that the recommendation was likely based upon our own experience based on this data. So this is a pre-procedure chest X-ray. As you can see, left side implant with a single chamber ICD dual coil lead. And the lead is a tine lead. So before we start the lead extraction, we need a thorough thought process to make sure we are going to have a very well prepared lead extraction process. At the Mayo Clinic, we have a clinical protocol, I believe, set up when Dr. Friedman was the director. So we stratify the patient with moderate, low, or high risks. So in patients with a pacing lead over 10 years old or ICD lead greater than 5 years, and we do the lead extraction in the operating room, hybrid procedure room. So patient usually under general anesthesia and with the radial arterial line, to monitor the blood pressure continuously. A TE is the standard and to monitor pericardial effusion and also tragus valve regurgitation that lead in relationship to the RA and the RV. For the patient prep is from neck to the bilateral thigh and ready for sternotomy. Venous access in this patient, we place the 9 French sheath in the left side femoral vein for potential fluid resuscitation and transfusion. And for the right side sheath placement, so we place the 12 French sheaths for bridge balloon placement and the 8 French sheath in the right side femoral vein for potential femoral station upsize.
That's very comprehensive, Dr. Cha. So in our patients, we usually have the cardiac surgeon and the perfusionist waiting outside. Sometimes they scrub with us, and this helped us avoid any major catastrophes over the years.
Thank you. So in this patient, we asked our CV surgeon to do a video-assisted thoracotomy. And we have done more than a dozen patients in the very selected patient population. So these patients must have very high risk for SVC tear, such as in this case is 20 years old dual coil ICD lead. From our experience, 60% patient with the massive bleeding is due to SVC tear. So we are very cautious about this complication. And the patient must have no previous sternotomy. So as you can see in the right side photo, you can see this is the superior part of the SVC, and then here is the right atrium. And you can even see the phrenic nerve along the lateral side of the SVC. So we can visualize the SVC and then potential if the extraction sheath going through the SVC, if it's a pending tear or perforation, we will know earlier. And then to avoid that, or if the tear occurs, then we can have an early diagnosis. So this is the setup on the left side figure with the VATS port inserted in the anterior axillary line. And then details I'm going to leave to Dr. Agami to give a discussion. So this is the first cine we take after we are ready after the VATS placement. As you can see, the intubation and the lung ventilation is only through the left side of the lung. The right side of the lung is collapsed by injecting the CO2. And here is the VATS port insertion. And the TEE probe, as you can see, and the N+ wire all the way from the IVC up to the jugular vein. And here we inflate bridge balloon. And to test the balloon, then we deflate the balloon and pulling back to the IVC position, ready for the use if needed. So next step is to manage the pocket. So pocket was dissected and to free the lead. And then, of course, with the 20 years old the lead, so it required significant dissection in this case. And subsequently, I amputated the lead and used a universal locking stylet and locked the lead in the place. I like to use one tie compression coil to compress the lead to the locking stylet. And because this patient has a 9 French defibrillator lead, so I select 14 French laser sheaths to start for extraction. So this is the 14 French laser sheath. Was advanced very slowly with some difficulty going through the left side subclavine. And then you can see the outer sheath is here for the support. And at this point, just very close to the proximal coil, and I encountered tremendous difficulty to advance the laser sheath further. And if you look at them more closely, it seems the beginning of the coil start having, a little bit unraveling here. So at this time, I thought one is a difficulty to advance the sheath, maybe because we have a hard tissue around. And secondly, we are turning the corner from the innominated vein towards the SVC. So I decided to switch to the 11 French tight rail sheath.
So, Young May, before
Yeah.
we move on, one of the audience questions is, other than this high-risk dual coil leads, are there any other scenarios where you would consider this VATS thoracoscopy? And if you do like 1,000 cases, how many would you normally do? How often are you doing this VATS-based guidance for these high-risk procedures?
Yeah, thank you for the question. We, as I mentioned, we probably have done about 15 cases. So it's really in a very selected patient. They cannot have a previous sternotomy. That probably excludes at least 40% of the patient who are not eligible for this. So it has to be the high-risk patient. It's not for everybody. And then because that procedure, it's relatively low risk, and Dr. Agami can give some more statement on pros and then cons. And then so that's why the risk we have to balance if we do the VAT, it doesn't extend or prolong the procedure time much, because it only takes 5 minutes for the surgeon to do it. It's a matter of to avoid the complications, and really is beneficial for the patient. So we switch to the 11 French tight rail mechanical sheath. And as you can see, we still encounter some challenging here to advance the sheath. So I want to mention about why we select the tight rail rotating dilator sheath. And one of the feature is this rotating blade is shielded. So as you can see, the blade is within the tight rail sheath. So that can minimize the possibility of transect the lead. It's not absolutely safe, but I think the chance relatively to be low. And then for the evolution sheath, the blade is a little bit outside of the sheath, and just keep that in mind. And because the sheath is relatively soft, so I like to use the outer sheath for the support. This is a very practical slide made by Dr. Mapuro. As you can see, we commonly use the laser sheath and the tight rail sheath and the evolution sheath. So how are we going to match the size? So let's just look at, I initially select the laser sheath, 14 French. That is the size for 9 French defibrillator lead. So the blue circle represents the maximum diameter of the laser sheath, and the green circle represents the maximum diameter of the outer sheath. So the laser sheath 14 French actually is about 10.2 French. So just keep this in mind. So that's why this is a size for the 9 French lead. So when I need to switch to the tie rail sheath, so I have to upsize slightly. So as you can see, the maximum sheath is 11.2 French, and the outer sheath is 23 French. So on the left side, the 9 French tie rail sheath is for the pacemaker 7 French lead. So come back to the tie rail sheath advancement. So even though with a significant effort here, and pretty much the sheath kind of stuck in the middle of the proximal coil. So what do we do at this point? So if we are not making a great progress. So one thought in my mind was, are we lack of downward reading force? Because as you can see, the lead is really moving around with the extraction. So it's not steady with a reading force from below. And also you notice that by the yellow arrow point out, the locking stylet actually already back close to the proximal coil. So we lost the good attraction force to the end of the lead, which we intend to do.
So Young Mei, it's impressive that whenever you try to tug on the lead, the whole mediastinum moves. Whenever I see that, that is actually very concerning, showing a lot of fibrosis around the coils. Just that losing that locking stylet support makes the procedure a little bit more difficult than it is intended.
I fully agree. And then because we really don't have a good force to the end of the lead, so we really lost alignment at this point. So I decided to place the snare from below. So I placed a EPT catheter wrap around or grab the ICD lead. I think it's best seen by the right side figure, the right side illustration. So assuming this is RV lead, and then we use the EPT catheter through the workstation. I upsized the 8 French to 16 French workstation sheath. So in this way, I can place the EPT, 7 French EPT, and then grab the lead, and then curve the lead, the EPT curve downward, and then in this way, I can put the gooseneck snare and to grab the lead tape. So in this way, we can have a very good downward force. As I see in this scene, so you can see a very straight line downward. However, the tie rail was still challenging to be moved forward. So at this point, we have to think about what's the problem? What's the next we can do? So either is because of significant calcification around, so the even tie rail is not able to separate the lead from the fibrosis, or maybe because too much tissue on the front and causing we call the snow plowing phenomenon. So it's easy to test that at this point by advancing the outer sheath. So I did that. So as you can see, the yellow arrows pointing out, I attempted advancing the outer sheath. As you can see, the outer sheath all the way going down towards the tricuspid annulus. So that confirmed it is snow plowing with excessive tissue on the front.
So Youngmin, you clearly show that, without that downward rail, it would be a lot riskier to push that outer sheath because you would be transferring those forces to the lateral wall of the SVC. Having that downward rail and having this VATS visualization, it increases your comfort on advancing your tools from the top.
Absolutely.
It's a very nice illustration.
Yeah, absolutely. It's a great comment. So when we realize that there's a significant excessive tissue on the front of the sheath, this is the time to take the sheath back and then trying to clean the sheath. And then I try to pull the sheath back, but it's too much junk or tissue really jammed between the lead and the sheath. Unfortunately, as you can see, the lead is completely unraveled at this point. And this is the proximal coil. It was completely outside of the pocket. And then from the proximal coil to the distal coil, and it was pretty much stretched very long. And this is the pace sense conductor. So you may not be able to see very well here. I just draw I draw the line, as you can see. So the lead is still connected. That's a good thing, is the lead is still intact, not broke.
I think this is one of the issues when you use the mechanical sheets, especially when the cutting coil is on the inside, you can basically eat into the components of the lead, causing it to unravel. Something to keep in mind when you're using the mechanical sheets.
So the green arrow point, I think this is the adhesion point. Here is the distal coil kind of really adheres to the tricuspid annulus. And then the red arrow, if you pay attention to here, and then you can see the locking stylet. Actually, it's already here. So it's outside of the body. So at this point, this unraveled lead will not be helpful. Actually, is really interfere with the lead extraction. So I cut off this unraveled lead and then use the bulldog extension and connect it to the proximal coil wire here. So in this way, I can have the force to holding force for the lead extraction. So now I re-advance the tight rail sheath. As you can see, the sheath is all the way advanced to the distal coil location at the butt tricuspid annulus level. And then, do you have a concern at this point? And I did, because we had another challenge here is the sheath is towards downward here, right? However, the lead is horizontal. So we're in the 90-degree angle here. As Dr. Mapuro alluded earlier, if we keep cutting, we can easily transect the lead. Then we will lose the lead and then leave the distal coil in the RV. So what do we do at this point? So what's the possibility? One is the hard tissue with a calcification, and then another possibility is it more excessive tissue causing the snow plowing this here. So I have to pull the lead back in the traction way to pull the lead backwards more, and then to make a better alignment. And we did achieve a better alignment here. So, and also as the yellow arrow pointed out, I was able to advance the outer sheath over the distal coil at this point. So definitely it's not because of the lead adhesion. It's more because of excessive tissue on the front of the tight rail sheath. So
a lot of times,
yeah,
a lot of times we don't see this extra tissue on TE, or it's these maneuvers, not able to advance the inner, but able to get the outer over it. That gives you a clue that there is snow plowing present. As Dr. Cha presented, just a very elegant visualization of how she overcame that different angulation, difficulty in advancing the inner, and that recognizing that snow plowing in the last 2-3 slides.
So now all we can do is to do the counter traction because the tight rail sheath cannot advance further because of the excessive tissue. So all we have to apply is the outer sheath for counter traction. So we hold this for quite a few minutes. And now the next thing you see is the RV lead tip came off from the RV apex successfully. However, the lead still connected to the RV with some tissue connection here. So we continued put counter traction. We have to watch the blood pressure because, as you know, when we pulling the sheath from pulling the lead from RV can cause hypotension. So we have to do the counter traction for a couple of minutes, and then we have to stop for a while to make sure the blood pressure coming back, and then re-engage and to do the counter traction.
Dr. Cha, how hard do you pull when you're holding pressure for that long? Is there any measure that, on fluoroscopy that you could use, or is just mostly judgmental?
I think for this case, I just did the judgment because I was pulling back, but you don't want to cause a lot of PVCs. You don't really want the blood pressure drop too low. So I think it's really a balance, but you have to have a force. And I'm back the question to you, Dr. Mapuro. I think you did some study on the force study on the lead extraction. Do you have some comment on this?
Yeah, no, I think, more than 15 grams of force, we were seeing like RV inversion. So I think, as you alluded to, PVCs, seeing that RV inversion on the TE, and it's just more like gradual force than abrupt force that would lead to that release of the lead. A TE is my guide. I pull back, I cut back on the force when I'm seeing a lot of RV inversion or a lot of TR.
Good. That's a good comment. And then usually at this time, probably last minute, we usually like the echocardiologist to stand by and to watch, how severe the TR is and where's the lead position. So with the continued counter traction, and then and as you can see, even the lead coming to this point, you still need to put a force, still have a strand of the tissue binding the lead to the RV. So until the last moment, and then we remove the lead completely. So this is the photo we took after the lead removal, as just let you pay attention to the lead tip. So as you can see, this is the distal coil all the way to the tine lead tip. It's a significant fibrotic tissue, and certainly you can see there's some myocardial tissue here. And then because this is not active fixation lead, so often for 20 years old lead, we take some tissue along with the lead out. So then all this entire segment is basically separated by the countertraction.
That's impressive fibrosis even for a gore-coated lead, right, Youngmei, for
Yes.
on the RV coil?
Yeah. Yes. And I just want to point out another case. It's a different case showing the importance of countertraction. And as you can see, this is the 11 French tight rail sheet. Again, similar to this case, stopped at the proximal distal coil, cannot be advanced. And then this is the outer sheath, really at the tip of the lead, applying for the countertraction. And then this is the photo from that patient. And then that illustrated that this is the tight rail sheath. It cannot really advance further because of the tissue. However, if they use the outer sheath, it's because the outer sheath on the tip is blunt, and so we can come over the tissue to apply for the countertraction close to the lead tip.
You alluded a very nice point before that once you're not able to advance the sheath, you pull the sheath out to clear the junk on the lead. Sometimes that itself will clear the snow plowing, and by re-advancing the sheath on, you may be able to make progress or upsizing the sheath. But these pictures clearly illustrate when you have that snow plowing, the strategies on how to overcome that.
Okay, so I think in this case, I stop here. I saw Dr. Agami is here. Let's invite Dr. Agami to address the VAT. People are interested in, how to do the VAT. What's the indication? What's the potential complications associated with VAT?
Dr. Agami is one of our cardiac surgical colleagues here. He collaborates with us for the lead extraction procedures and also for surgical AF ablation. Welcome to the webinar today.
Thank you, and thank you for having me. Can you hear me okay?
Yes.
First of all, I enjoyed the presentation. Congratulate you on all these difficult cases. I participate in a small fraction of them. You have built a risk prediction model that you can predict those are at higher risk of complication, and you decide to do those in the operating room with us present just in case. And fortunately, knock on wood, 99% or a majority of those go just fine as well. So what we discussed maybe a couple years back was to augment this just presence in the operating room with the videoscopic view of the heart during the extraction process, which will, in theory, give us a few benefits. One is to observe what was happening and give the feedback to your team. I think, Siva, you mentioned you see the whole mediastinum being pulled when you're pulling on the coils or the wires. You can see that very easily on the videoscopic view. So what we started doing is to put a 5mm camera into the right chest, insufflate the area with CO2 so the lung goes down, and we have a clear vision of the mediastinum. The SVC will be the most lateral structure that we will see. We won't open the pericardium, but in most cases, the pericardium is thin enough that you can see through. So we see the motions, we can, give you feedback, you're pulling too hard or whatnot, and you can see it obviously on the monitor at the same time with us. The other thing is that if for some reason you have a pericardial effusion from a trauma, then we can recognize it much earlier before the consequence of a tamponade happens. So you see the pericardium filling with blood before the patient goes into tamponade, we can make the diagnosis. and I don't know if Dr. Chow, you have a video of that or not, but and then there is the therapeutic effects of it. So we do have the capability of intervening on these. For example, we can put another port and open the pericardium, drain the blood into the pleural space to give us time and relieve the tamponade, so we can get to the problem and fix it in a timely fashion. Or if the tear is in the SVC and it's extra pericardial and it's bleeding into the right chest, sometimes we can easily suture that with a intracorporeal needles and suturing technique, which would then preclude needing a sternotomy, which will be, exceedingly helpful. So those are the benefits. Oh, thank you for playing this now.
Yes, I think
So
this is the one you get to us. So I just want to, because did you see that
Go ahead.
the blue arrow? You can see this is the sheath, extraction sheath in this location. It's going back.
You
Sometimes
want to
you can,
explain
yeah,
what the audience are looking at there?
yeah. See the blue arrow? So you can
No, in
see
terms
that's
of
the
the anatomy.
extraction sheath here.
Maybe Dr. Argami, you can give us, just an overview. Dr. Chow is pointing out the extraction sheet. Maybe you can give us, an overview, a surgical overview, what we're seeing.
Yeah, sure. I don't know if I have a mouse to highlight, but maybe I can annotate mouse. There you go. So can you see my mouse?
Yeah.
So basically, we're in the right chest, looking at the heart, and this is the pericardium. The phrenic nerve is down there, a very white structure way down there. The SVC is here, and the SVC and the innominate will be curving that way, going to the left side. So this your extraction device was seen here on the lateral aspect of the SVC, and then it was stuck, and then all of a sudden you saw it go down, which was when the adhesion was taken and it was released. So if you can play that part again.
Okay.
I think it was a little bit
I think
higher.
it's towards the end.
Right there, yeah. So that's the tip of it. It was up here, and then it gets released. So you can see this in real time and give feedback. The other thing is this is mostly the right atrium. And on this case, I think we also had a dimple while you were pulling on the right atrial wire lead, and the dimple went away as soon as that lead was disconnected. So you could see, now this is not an RV to get an RV inversion, but you can see the atrium getting pulled down and dimpled down. So it's an additional safety layer. And in addition to that, it can be therapeutic in certain scenarios, especially with pericardial decompression if need be, or if the injury is up high here and you drain into the pleural space, a suture can just fix that and avoid a sternotomy.
From this images, it's so striking that the SVC is so thin, you can actually trans-illuminate with our laser sheath.
Yep, it's almost see-through. Yeah, but again, your techniques, and you're very careful and safe that, a lot of times this obviously goes as smooth as always, and never have an issue despite this thinness. All the techniques that you mentioned earlier, all plays into it.
Are there any contraindications? Are there any patients that we cannot do this visualization?
Yeah, good point. So as you can, it's not completely visible down here, but the lung is decompressed down there. Now, if the patient had a right chest surgery, let's say a lobectomy or a bleb resection or a pneumothorax, sometimes you get significant adhesions in this chest, and the lung will be stuck up, so it won't deflate, so you won't be able to see the pericardium. And for that, you have to do significant adhesiolysis, taking down all the adhesions, which obviously is not, worth the effort for just visualizing the mediastinum. So the main contraindication would be someone with previous right-sided chest surgery. The second, less strict contraindication is severe COPD, because when the lung is deflated, the patient has to sustain oxygenation through one lung, that's the left lung. And if they have severe COPD, that they really count on both lungs to ventilate, then that also would not work. Other than that, no.
Can you also comment on the post-op, the morbidity with this procedure? What can the patients expect? And how do we code those risks to these patients?
Absolutely. So the risks are exceedingly minimal. This is just a 5 mm port, a single port, nothing else. It's put through the lateral chest. And at the end, a lot of times when the patient is otherwise healthy, we don't even leave a chest tube. We put a draining catheter while the patient is, getting extubated, drain everything, all the air out, and then suture it closed. So the patient doesn't even have a chest tube. From our standpoint, the patient, can leave the hospital the following day. And from a discomfort standpoint, because it's such a small incision, and the camera is only fixed in one position, so the nerves don't get damaged. The pain is also very minimal.
Thank you.
Thank you for all that information. And Dr. Cha, maybe we should ask the audience, see if they have any additional questions. If you guys, if any of you want to comment on, want to be a panelist, we can elevate you to be a panelist to talk. Or if you feel more comfortable sending your questions via chat, I'm happy to read them out and try to give you the respect, ask Dr. Cha about those questions.
We would love to hear your experience and maybe a different approach.
So one question is, do you always use an outer sheath? And maybe I would add another part to that. Do you cut your outer sheath, or do you use the outer sheath the size that comes in the sheath kit?
For me, I always to use the outer sheath because I feel the outer sheath gave more support. I cut the outer sheath maybe by 1 inch to 2 inch. So in this way, usually even you cut 1 to 2 inch, you still can push the outer sheath all the way to the RV to apply for the counter traction. And I just like the support. However, I have heard a different experience. The extractors have different comment. I know some extractors, they never use the outer sheath. So I think it's really upon each individual extractor's preference.
No, those are great comments. Just the outer sheath makes it stiffer, but that's the only way you can sometimes overcome the snow plowing. The other question is, do you have criteria? Do you have a set of criteria where you put up a prophylactic snare from below? What are the scenarios where you would try to use this downward rail?
It's a great question. Yeah, it's not 100% case I would do that because sometimes, the lead extraction may not be that challenging because sometimes you either use laser or tight rail or even evolution. I think probably some leads without too much adhesion, you probably with a few minutes, you are able to advance the laser or tight rail down all the way and remove the lead without much difficulty. But having said that, one is you require the lead really required a lot of basically the fibrosis really prevent you to advance the extraction sheath. And then secondly, really look at the importance of the alignment. So when you feel just like at the beginning, the lead is really moving in the mediastinum, I think for the safety purpose, if we know we have to put a lot of force, little by little, separating the fibrosis. In that case, especially when we turn from the innominative vein to the SVC, that angulation, I think it's better to consider the reading force from below.
Great comment. One of our attendees, Richard Lane, he says that he rarely uses the outer sheath. There is this polarization to use or not to use. One of the reasons he says is he loses that tactile sensation with the inner sheath. With lead extraction, it's mostly that tactile feel. If you're comfortable and if you're getting the results, that is the way to do it. It's more individualized.
Right. It's a very good comment.
Yeah. And another comment is when the lead disintegrates like this, when you have this unraveling, are there any specific precautions when you are trying to push this inner catheter and outer catheter? When should you stop, or when should you pull back on the force when we do this?
Yeah. At that point, we have to be cautious because we don't want to put too much force, and then because it's really because we lost the locking stylet. The only connection and is the conductor, and then I think we have to really watch it, not really transect the conductor at the point. So I think it's the balance, how much force you're going to push and counter force in that point, but it has to watch the lead, whatever left there, the integrity, and trying to maintain that force in your hand.
Great comments. I think we're coming to the last couple of minutes. Dr. Chum, maybe do you want to summarize?
So to summarize the take-home message here, for this case, and of course we need to have a careful procedure preparation. I think main thing is when the extraction sheath is not advancing. So what we have to think about for the next step. So is this because of calcified tissue adhesion? So if that's the case, I prefer alternating the laser and the mechanical sheath. Sometimes I will try evolution and as well, and then trying to see if we can get the calcified tissue separated. And then is it because the sheath and the lead alignment is not adequate? So do we need a reading force from below? So this is another important step to keep in mind. And the excessive tissue at the sheath tip, like this case. So we really try the outer sheath countertraction and then to achieve the success. So persistent countertraction in this case is the winner. So I think that's the entire case, and we're on time. And here, and then thank you for everyone. Siva, do you still have some quick question?
No, I think we covered all the questions.
Okay.
And we had a great show of people today. Our goal is to have this camaraderie, develop a network of extractors who are willing to share their ideas, and so we can advance the field. So we try to keep it minimal commercial bias. I would like to see your cases, your difficult cases in your practice, and we'll see you back in 3 months.
Yes, and then I think probably Siva, we keep a connection with everybody, so to see if any center want to present the case with us together.
That would be wonderful, and we will have also a diversity of speakers, non-Mayo external speakers. It will just increase the the richness of the discussion in this particular topic.
Okay, Well, thank you again for joining us, and have a good evening. We'll see you next time.